Yeah, so that's us at 1 o'clock now, so I think we'll just get started. Thanks a lot for taking the time to join us at this learning event for the Mental Health and Substance Use Protocol Programme. During the event, we'll be talking about improving interfaces, and we'll be joined by John Parker and Ian McGoldrick, both operational managers at Renfrewshire Health and Social Care Partnership, and Gregory Hill O'Connor, who's a strategic planning advisor within Healthcare Improvement Scotland. Next slide. Feel free to introduce yourselves in the chat, and I guess it'd be interesting to know what brings you here. So as well as your name and your role, what is it about this topic that interests you, or what are you hoping to get out of the event? And I'm Benjamin McAwee, Senior Improvement Advisor with the Mental Health and Substance Use Programme within Healthcare Improvement Scotland. So I'll be chairing today's event. And next slide, please. So if you have any issues with the tech, I already see that someone's unable to see the presentation, so we'll make sure we get a copy across to you. And maybe if you could send Abby a message on Teams or an email with the correct email address to send them, that would be great. And likewise, if anyone else has any similar difficulties, just let Abby know and we'll try and get that sorted out for you. Next slide, please. So just a quick run through of some of the MS Teams settings. I know that you're all probably pretty familiar, but on the picture there, you can see how to open and close the chat panel, so feel free to comment in the chat. Under More, you can record and transcribe. Clicking settings will enable you to use accessibility functions, so you can see live captions and mute notifications. Cameras are automatically switched off during the presentations, but we'll enable these during the Q&A session at the end, and same for your microphone. And then you can see there how to leave the meeting as well. Sometimes if you have technical difficulties, you might want to leave and then come back. And sometimes that sorts it out for you. Next slide, please. And we'll also be using the Q&A functionality of MS Teams for the final session of today. So if you have a question to any of the presenters, then feel free to follow the instructions there to open up the Q&A tab and post your question, but you can also give thumbs up to other questions that you'd like an answer to, or use the comment option to respond to questions as well. Next slide, please. And this session will be recorded during the presentations, but we'll turn the recording off during the Q&A just to make everyone feel a bit more comfortable and be able to ask the questions, or we can pull them out of the Q&A function, as we said. And next slide. So yeah, I'm just in the middle of doing welcoming and introductions, and then I'll do a very brief few minutes just around a couple of reports that have been published recently, and also linking back to the Mental Health and Substance Use Protocol and how interface meetings fit within this. Then we'll hear from John and Ian about their experiences of running interface meetings within Renfrewshire, and what that's helped them to achieve, and also how it's helped them identify some next steps. Then we'll hear from Gregory Hill O'Connor, who's talking about some of the learning from Tayside, where they've had their first year of the multi-agency consultation hub in Dundee. He's doing that presentation on behalf of Dr. Jennifer Breen, who's been really instrumental in that work. And then, as I said, we'll have a bit of a panel discussion before some final remarks. So next slide, please. Yeah, so I just thought it'd be useful to bring your attention to two reports that were published in the past number of weeks. So the COSUM report, the Co-occurring Substance Use and Mental Health Disorders report that's been published by the Royal College of Psychiatrists, it has a series of recommendations within it and suggested ways of measure and implementation of those recommendations. It's a really helpful report because it also looks at some specific presentations such as cannabis and acute mental health, alcohol and depression, sedatives and PTSD or trauma. And for each of these presentations, it has some key information and considerations. And I guess why I'm bringing it to attention as well, because it makes some recommendations around how service structures, so how mental health and substance use service structures should interact and how they should function for these specific presentations, as well as more kind of overarching sweeping recommendations for the kind of things that areas should be considering. So it says treatment plans should be developed based on a person's needs, acknowledging that these might change. Joint working between mental health and substance use services will be essential to support and treat people with more severe co-occurring conditions, and joint working will be determined by local systems. But some examples of this might include joint working protocols, joint multidisciplinary team meetings, communities of practice, co-location, ad hoc professionals meetings, shared learning or training sessions, and involving people with lived experience within treatment systems, as well as ensuring that there's systems in place to monitor access and outcomes. And goes on to say that this is likely to involve some discussion and overcoming some of the hurdles around data sharing between the different services as well. And then the other report there highlighted is from a recent roundtable looking at co-occurring conditions. And essentially what it says within that report is that they want to see a move towards more collaborative and integrated care models for people with co-occurring conditions. And this might start with closer liaison between mental health and substance use services, for example, holding these interface meetings to improve care coordination and address gaps, but then really using this as a stepping stone to start to develop accountability structures for both mental health and substance use services to be able to better support people with co-occurring needs. And I think that's something that both touch on in terms of that joint responsibility and making a kind of joint reporting effort as well for thinking about people with these conditions as a way of being able to learn from the outcomes that they're experiencing and be able to continuously improve services. And through the presentations today, next slide please, we'll hear, I'm sure, about how interface meetings in themselves can begin to identify some of the other work that needs to be done in local systems and how they can help to implement the National Mental Health and Substance Use Protocol. And I've got some examples of what that might look like. So some of the conversations around specific cases might lead to the refining of local standard operating procedures, might support the development of local protocols for how services will work together. But then it might also address or identify some things that need to be addressed, for example, increasing awareness of policies and procedures to staff, putting in place measurement plans to enable some of that learning and continuous improvement that I've talked about, identify and address training needs of staff so that staff are able to work slightly out with their specialism up to a level that they're comfortable with, but that someone within that specific service would be expected to know about. Say, someone in a substance use service would be expected to know about anxiety and depression and coping strategies so that they're able to explore some of that with patients, and also so that people within mental health services have a kind of basic awareness and understanding around harm reduction techniques and motivational interviewing, that kind of thing. And they might also identify where not enough information is being gathered by staff to really be able to appropriately address someone's needs. So that might lead to agreements on some screening tools that you might want to use consistently across services, agreeing pathways for people with different presentations. And some of the other work that you might want to do to meet the protocol is developing relationships across services, because in many of the areas that we work with, that seems to be one of the real fundamental things. Having positive relationships between staff across services enables that sharing of formal and informal advice and takes away some of that fear of asking for help. But interface meetings can also build better awareness amongst staff of what's available locally and how they might help, what kind of interventions they would do, and therefore, who might be most appropriate to go there. And they should also help with consistently applying the 4 quadrants model of care for people with co-occurring conditions. So yeah, when we're going through the presentations today, I guess what I'd like to emphasize is interface meetings are one very practical thing that you could do within your local systems, but also to see them as that kind of stepping stone to that wider system change that will improve outcomes for people, will improve experiences of staff, and really improve the services that are set up. So I'll introduce John and Ian just now. So John is a mental health and addictions operational manager who's been based within addiction and recovery services since 2020, managing Circle Recovery Hub and shared care services. He's worked in Greater Glasgow and Clyde Addiction Services since 2010 and previously worked in acute inpatients, adult community mental health teams and elderly community mental health teams in Inverclyde and mental health day centres within West and Bartonshire. Whilst Ian is an operational manager for adult and older adults community mental health services and has worked across various care settings with over 17 years of experience working in addiction settings too. So you can see that they both have that mental health and addictions background, so therefore hopefully some of the insights and experiences that they'll be able to share will draw upon that background that they have and be able to talk about the strengths as well that brings to some of the meetings and some of the relationships that they have within their services. So I'll hand over to yourselves.
Thanks very much for inviting us along today, just to talk about the interface working that we're doing. We thought that to begin, sorry, I don't know if it's moving. We thought to give you a history of what was actually happening in Renfrewshire prior to the implementation of the interface meetings that we have, because historically it's quite important to the decision making about how we got to that. So in Renfrewshire, there was an interface document, and that sat alongside the Greater Glasgow and Clyde document for addictions, and that was about the patient journey, and it's about kind of when to refer to services and how they should interact when they're kind of dealing with referrals. So, for example, if a patient was to attend in crisis, what each service should do. So that was kind of sitting there. But also alongside that, we also had in Glasgow historically a comorbidity team, and the comorbidity team had kind of changed as well round about this time. So they were a team that were kind of proactive, that dealt with people with both severe mental illness and addiction issues, and their kind of remit changed where they started kind of step back from that, and they basically came into the community mental health teams and began to teach the CPNs and the kind of social work staff that were there as well about how they should manage somebody with comorbidity issues. Renfrewshire itself, though, actually retained their comorbidity aspect, so they kept that. So prior to kind of John coming in place, what happened was this kind of comorbidity patients were kind of managed by that team. So it meant that when it actually came to the interface meetings pre kind of 2020, 2019, the kind of issues that they spoke about were basically those patients that kind of fell in between kind of grey areas. And there was a lot of kind of to and fro in relation to the kind of management of patients. They also discussed kind of issues between the services and anything that was kind of arising for them. So that meeting kind of occurred quarterly. And there wasn't really an emphasis on actual integrated interface working between the two services at that point. In 2018, 2019, there was a review of the Renfrewshire addiction services that recommended that they kind of come in line with Greater Glasgow and Clyde and transform into the alcohol and drug recovery service. So they went through quite a significant period of change at that time. And as a result, at that same time, the consultant psychiatrist who was kind of taking on comorbidity patients and prescribing for them all, he had retired. So it meant that ADRS, the Alcohol, Drug and Recovery Service, were kind of left with all these kind of comorbidity patients for whom they were responsible for prescribing with, because the Renfrewshire comorbidity team sat solely with the addiction service at the time, and there was very little input from mental health services at that time. I came into post in 2020, just at the time when the pandemic cut, and at that point, kind of all interface working stopped completely. It kind of ceased. And ADRS were kind of going through change as well, setting up their new service and kind of looking at new ways to deliver services to addiction patients across Renfrewshire. So we got to a point where the community mental health service was really kind of under severe pressure as trying to come out of the pandemic. Just to give you an idea, We had the kind of national lockdown, but for Renfrewshire during the pandemic, it kind of went on for a year because we had the kind of local shutdowns as well, and that lasted for almost a year for us in Renfrewshire. So there was a lot of tension, there was a lot of staff that were kind of burnt out, and then we had GPs who were obviously under pressure as well, and they were sending referrals to both services. So they had this kind of scattergun approach, which caused a lot of confusion and also caused a lot of tension between the services because everybody was in kind of survival mode and just trying to see to their own service. So there was issues with regards to that as well. On top of that, there was also the introduction of the mental health assessment unit in Glasgow. That was about managing those patients who were in crisis and requiring a same-day assessment for patients who are not open to teams. So that had an impact on the actual Greater Glasgow and Clyde policy, interface policy at the time about who should manage the patient and whether should manage it. So the policies were kind of all out of sync and weren't really kind of matching up at that time. So it caused a lot of confusion between the three areas, between mental health, ADRS, and also the mental health assessment unit. And from that, there was a number of critical incidents that arose as a result of that because the kind of protocols were not being followed properly. And ADRS were also left with the patients who were comorbidity, so they were left with the kind of prescribing of that also. So it was very clear from these critical incidents and from the kind of tension between the services that we had to kind of meet up and look at how we can actually work better together. Because the staff were so intense at the time, were so stressed, that we kind of felt the need to try and take that stress away from them and find a way that we can support them to do that. Thankfully, John came into post and became established in the post, and thanks to him and the kind of hard work that he does, he agreed to meet up with us, and we set aside kind of meeting 2 monthly and looking at the issues that we had. And when we looked at those issues, we quickly found that the issues were actually to do with the kind of pathways and the protocols that were in place. We also found that just with the number of issues that were arising, that we decided to meet monthly. And so we painstakingly went through the Greater Glasgow and Clyde kind of pathway and the local protocol that we had, and we developed a new one that sat alongside the new Greater Glasgow and Clyde interface document. We decided to have an interface meeting and to kind of reintroduce that, and we have that monthly, and we invited all the team leads and operational managers from addictions and mental health because both services are integrated services. We looked at what we would need in order to make that meeting be successful, and we completed an SBAR and a terms of reference, which we then presented to our senior management teams, both individually and together to our head of service as well. So this was accepted because we could see the need just to do with the level extent of need for patients that we had. And we set up the meeting. So the meeting has kind of developed as it's went on. We kind of set up an idea, and then that has kind of evolved over time. We also had help from the Alcohol and Drug Partnership as well at the beginning to help us initially set them up. So at this meeting that we have, it's co-chaired by both Alcohol and Drug Recovery Services and ourselves. So me and myself and John both chair that. And the membership of that meeting is we have all the team leads there. We've invited psychiatrists as well. We have had input from ADRS psychiatry. For community mental health, it's been more difficult to have that. We've also had psychology, and LD services have attended, I think, on 1 or 2 occasions. So each meeting that we have is recorded by the business support that we receive from Alcohol and Drug Services. And we have a situation where we're able to talk about complex case discussions. So just a wee bit about that. We do work well together, and there's a lot of kind of working that's now kind of going on because it's been shared through the team leads and within the teams about this interface working. So there is cases that we're working well, but there's some cases that we kind of come together and we have case conferences out with the MDT. And when there is difficulty around that, or where there's decisions that are not being reached, we can then bring those cases or any other cases where we felt that there's maybe some tension around that. We bring these cases to the interface meeting that we have monthly, and so we have quite a broad, complex case discussion around them. We can also bring any deaths that we've had, so any kind of significant adverse event reviews that we've had, or kind of local investigations that we had, we can also bring the findings of them to that as well, and look at the issues that have been raised and look at ways that we can kind of help our own policy and protocols and how we can try and prevent certain issues happening again in the future. At this meeting as well, we look at the training that's available, and we're looking at a joint kind of training session that we're able to give staff, and also to help staff in both areas to be able to provide the mental health and addiction support that they require in order to carry out care. So we find a number of patients will attend only one service, so it's about making sure that our staff are skilled in order to ask the appropriate questions, the correct questions, that then allows to bring it to the meeting and to receive the guidance and that we can from each other's services. So the local and board-wide policies that we have are discussed and they are amended at this group as well. We spend a bit of time looking at that just to make sure that it is patient-friendly, and also because Renfrewshire has different services to Glasgow, so there is kind of slight changes. So our local protocol complements that, so it's not different. It just sits above that and complements what's already there. And kind of any reports that we have or kind of updates that we have are taken to both governance meetings as well with the head of service, and we discuss issues there, and they're also agreed. So within Renfrewshire, we have, at this present time, we have 2 community mental health teams, one in the Charleston and Paisley and one in Mile Mill, which is also in Paisley, but that's for the rest of Renfrewshire. And we also have the intensive home treatment team, which is our crisis service, which is different from the rest of Glasgow. And that's what I mean by there was a lot of kind of difficulties around how we manage patients in crisis. So for our Renfrewshire alcohol and drug recovery service, they're also in Paisley, and within there they're situated their access team and their core team. We also have the Tola unit, which is at our Dyke Bar Hospital, and they look at kind of the shared care service that they have. The kind of team run from that. There's also an alcohol and drug recovery service called Circle, which John also is head for. He's a very busy man, and that's been proven to be very successful in supporting patients in recovery. And then I'll stop talking and I'll hand you over to John. Thanks for listening.
Yeah, so just to say, when we initially met, we discussed like step models of care for mental health referrals and vice versa, step models of care within addiction services. We found that it helped to improve communication. A lot of staff weren't aware of all the tasks that each service had or what services were out there available for both addictions and mental health service users. Then there was an overview of the alcohol and drug partnership and mental health teams. It was just to clarify what each service provides for the local area. We also discussed, it was MAT Standard 9. So basically that was in where ESPA, it was basically where MAT Standards 9 was a lot of stuff related to addictions and mental health services, related to like joint training, joint protocols, and so we've been developing, sort of looking at developing training from that. And the main thing we sort of worked on was a local psychiatric emergency flow chart review, which was basically in our local interface, and there's one in the Greater Glasgow and Clyde, but we were finding staff were wandering from this. There's a flow chart at the end of each sort. Staff are wandering from this and missing out points, which is causing more distress for patients and staff as well. Fortunately, within Renfrewshire, the team leader works from the IHTT, he can provide training. So he provides training for addiction services, which has been quite helpful. We're presently in the process of trying to engage them to do an update for staff because we've had a lot of staff changes within addiction services. And I believe Ian provides it for your own service every now and again as well. Next slide, please. So as Ian was saying, we were developing the local interface SOC, which hadn't been updated since 2014. At the same time, Greater Glasgow and Clyde was updating their SOC, which was under review, but we decided just to go ahead with our own in the meantime, and then see how the Greater Glasgow one turns out, and if there's any amendments we need to make to our own, we'll do that once that's out. So we're looking at up-to-date SOCs from other areas that we could find. We brought SOCs along to our interface meeting, like the Greater Psychiatric Emergency Plan and Clyde Mental Health Assessment Unit SOC. So they were quite helpful in helping us develop our own interface. So next slide, please. Other documents we're looking at was the Scottish Government Away Ahead and the Scottish Government co-occurring on substance use and mental health concerns. Basically, they gave us help to our local interface protocol, and they highlighted the 4 quadrants model and also identified training for mental health, substance use and trauma. Both of these documents go over that. Next slide, please. There are things we've implemented with case discussions. So initially, our case discussions were maybe just minuted, and then we decided we should be writing for a lot. We've got all these team leads and operational managers together. We should be uploading them onto our electronic records. So we've started doing that, and then we've did the joint EMIS directs just recently be set up. We discussed it at our last meeting last week. So team leads can put cases in here. We moved the case discussions to the start of our meeting, so as if any external services or other care managers could come along and maybe discuss their cases. And as we're saying, we'll record everything on our electronic system so that everybody can see what decisions were made. As part of this as well, it was Benjamin that suggested we should be auditing it. So we have started a spreadsheet to audit it. And part of that spreadsheet is the learning outcomes of most of the cases we've discussed. Most of them seems to be either a breakdown in communication or people not adhering to SOCs. So from that, we've decided probably we need to teach people SOCs rather than just distribute them. Ian and his own team, thanks to your own training that you'd set up, Benjamin, we discovered about high incidence of blood-borne viruses within mental health services. And Ian and his own team in mental health services have been looking at BBV testing, treatment, and also naloxone by mental health services. So it's early stages for that, but trainings has been arranged. What I've added next is a mandatory joint training plan and induction has been developed. To be fair to mental health services in Renfrewshire, when I first came, team leaders there invited our own RMNs to go along and shadow assessments within mental health services, but it doesn't seem to have been taken up by mental health RMN within addiction services. So we probably need to do some sort of mandatory thing, to have specific days where people attend. Joint assessments, joint care plan and shadow opportunities is stuff that we're looking at as well. And probably the next thing we should be doing, and so far we've all just been MS Teams. We originally Ian tried to arrange face-to-face within his own offices, but we need to probably do that where communication would be a lot better between team leads. Basically that's me, thanks.
Thanks a lot for that. Yeah, there's a lot in that, and I'm sure we'll get some questions later on. I see there's already one in the chat that we'll come to in the final session. But yeah, thanks for sharing your experiences and sharing some of the challenges as well and what led you down the route of doing the interface meetings, but also the kind of benefits that it's brought to you and being able to identify some of those things that you can do within your local system. It's a common theme across local areas that it does start to identify some of those training needs and I guess the benefits of shadowing opportunities. And then there's always that challenge of, how do you free up staff, clinical capacities to be able to do some of these things, but the benefits it bring can reduce some of the frustrations and the tensions further down the line. So there's definitely merit in pursuing some of the things that you've already identified. And I'll pass over to Gregory now to talk about the Dundee Multi-Agency Consultation Hub.
Hello. Yes. Thanks for having me, and apologies on behalf of Jennifer Breen, who's unable to speak on behalf of this. As Benjamin said at the beginning, she's really instrumental in setting this up, although it was quite an incredible effort on behalf of a wide range of stakeholders that I'll talk about throughout the presentation. But as the title suggests, this has been a year now that this has been up, so I'm just going to go through kind of a bit of the story of the development of the hub and then some of the impact. So I guess starting off in terms of what was trying to be achieved. So through a long kind of range of kind of exploration of the services, a bit of self-reflection around some of the gaps, thinking about the national reports, such as ending the exclusion, but then also some of the local sort of Dundee and Tayside specific reports, such as the Strang report and the Dundee Drugs Commission. There were these sort of four kind of very clear kind of aims that we wanted to do, and that's very kind of simple and straightforward, but it was essentially looking at improving access to a range of services, understanding the complexity of people's needs. So basically making sure that pathways are cognizant of complexity rather than necessarily just going into specific services. Working collaboratively to improve, to deliver improved experiences for individuals who use and need the services. So again, that's looking at actually, once you're in the service, what does that care and what does that collaboration look like? Support the identification of substance use or mental health difficulties. So that's obviously you've got, your condition specific assessments and things like that, but it's also actually how do others identify that and look at and pulling in supports if required. And then ensure that there's clear responsibility and coordination of care for individuals, including open channels of communication. So working with the mental health teams, the substance use services and third sector stakeholders as well, across all levels. So, variety of grades of, from very operational staff to the sort of more strategic staff as well. Looked at having a multidisciplinary team. So that's community mental health teams, drug and alcohol recovery service, and the mental health and substance use third sector services. The aim was, again, proposal to have something to discuss complex cases either at the point of referral or at a transfer point. So that's, if there's a case coming in that's potentially not that there's questions about whether it's the appropriate service, it's having a discussion at that point rather than having that sort of handing back or sort of asynchronous referral process, and then but then also transfer point. So if there has been something where someone's been discharged or moved over between services, make sure again there's a conversation happening at that point. So again, collaborate and agree joint assessment, formulation and care planning. So similarly, as I say, is having that space to agree some of that, and then having that agreed name professional and service. It was also then looking at sharing up-to-date mental health and substance use kind of treatment pathways and referral criteria. So as well as it being that sort of quite operational sort of case conversation, it's also, as I guess similar to what John and Ian were talking about, it's just that place to learn about other people's services and to get an understanding of how other services work and what they can and maybe also can't do in specific cases. So in terms of the membership, it's a bit small there, but hopefully we'll send it out and you can zoom in on your computers. But essentially there's sort of a core membership that have this weekly discussion at the multi-agency consultation hub. So look, and again, it's that what I've just said in terms of having that joint assessment, formulation, care plan, care coordination, bringing in additional services if needed, transferring cases if appropriate, and then supporting it to crisis, and then also might wish to consider CPAs as well. So within that, you've got your statutory mental health and substance use services, but then you'll also notice within that we've got some of those third sector ones as part of that core membership. So that's We Are With You, Tayside Council on Alcohol, Hillcrest Futures, Positive Steps, Advocacy Services, and Penumbra. And then within that sort of outer ones is basically the sort of broad range of organizations that can be brought in if required. So significantly there we've got housing, so if there's and homelessness services. So I think that there's been examples of cases where they've been brought in to try and discuss a case and see how that they can be closer working with some of those mental health and substance use sort of specific services as well. Women's aid as well, similarly kind of bringing into looking at different ways of supporting people in collaboration, and similarly like psychology and GP services as well. So there's a very flexible approach to the sort of the discussions and the membership that's in that, very much led by what it's deemed, who's kind of sort as being able to help. So it's not necessarily organizationally led, it's kind of led by the needs and how people can support individuals. So basically the way into the MAC, so it's a lot of the time it's for people who are accessing services, so they've been accepted or referred into mental health services or substance use services, and also third sector services as a route, and it's where there's a suggestion or a thought that there might need to be an escalation of support or bringing anybody else in. There's some agreed tools to support that. So they've been using the Assist Lite screening tool, which I know some of you on this call will be aware of, for basically, and that's to help mental health services get a bit of an understanding on what the substance use, what the scale of substance use with an individual is, and give some suggestions on what support might be required there. So if someone's taken a lot of having quite high substance use, that can be flagged, and that can potentially be a discussion at the MAC. Similarly with the Core 10 and the trauma screening tool. So in terms of the sort of key figures around what it's achieved, I suppose. So within the last 12 months, there's been 61 individuals discussed at the consultation hub. There's been 94 discussions, so obviously there's been some repeats there. I think for me, this is one of the key bits of statistics, is that 46% of the referrals to the MAC have been from the third sector, and I think that's a real testament to basically how this has also been used as a really good route from third sector into statutory services, because we know that that's a big challenge for third sector services in terms of some of the circuitous routes that need to be done if there is a referral required. So in this particular example, and maybe it's on one of the later things, but I'll say it now anyway, just in terms of some of the learning and how they've taken a really flexible approach to this, which I think has been really effective, is that there was an agreement within the MAC that within the consultation hub discussion that the community mental health team would take on this person from one of the third sector services. However, because of their referral routes, they said, but you have to send them back to the GP and then get the GP to put in a referral, and we'll accept it, no problem. And that was sort of queried a little bit and say, well, actually, why does that need to happen? And so then there was basically a very quick and easy fix in terms of the community mental health team saying, okay, fine, we'll take referrals straight from this meeting, and we'll allow that. So that's been really helpful, and I think quite empowering for a lot of the third sector services. And again, it just makes it very much easier for individuals. It makes those transitions a lot seamless. And I think, again, it also presents that picture of, this is whole system working. And then likewise, we've got, from the discussions, you've got 89% of the people are getting support from more than one service as a result of those discussions. And again, that shows that people are getting their needs met from the right people, rather than potentially a single service holding quite a lot of responsibility around supporting needs that maybe they're not necessarily set up to do. There were a couple of interesting sort of dynamics in that. So, because I think one of the things as well that they're saying is some of the ethos and the principles of the consultation hub is it's not about just handing over care. It's not about sort of almost trying to pass people over. And one of the that there's a lot more advice sort of being given, and there's a lot more awareness of where it's best seen, where people are best supported. So when we were sort of looking at the breakdown of statistics, we had noticed from the evaluation that there were, I think it was 2 or 3 cases where they were screened and it was noted that there was high levels of mental health and high levels of substance use need. However, they were not being seen by more than one service. And when sort of asked about that, it was because within that discussion, it was felt that the person, just in terms of continuity of care and feeling more comfortable within a service and with people that they know, that they actually just remain within one of the services, but that actually there was then a plan to bring in expertise from the other service without the person feeling like they're sort of being moved around, because they've built up quite good relationships with the wider staff team within that. So it was then about how do you bring in that additional support within that service for people who really need that sort of continuity and that sense of comfort, I suppose, and trust. So that was really interesting sort of learning from that. And again, I think that speaks to the benefits of this sort of consultation hub, where you really can have these discussions, and it's not the case of just sort of it's a very structured regular meeting for these discussions, and it's not just about sort of putting referrals here and putting in referrals there, which often leads to that sort of what people often describe as sort of bouncing around services. And I think speaking to that, some of the feedback that we've got from people who've had their cases discussed is obviously this is still quite short term, but these two are sort of indicative of a lot of what people were saying is more aware of what's going on to help me. So before, it felt like they were being kept in the dark, and just feel like people are understanding difficulties better. And I think when we're thinking about recovery and when we're thinking about people's experiences, a lot of the feedback we get is from people with lived experiences. It's not so much. It's often not a deficit in the actual support they're being given. It's often that sense of hope, and that sense of sort of feeling cared for and feeling looked after, which again is really important when you're looking at what could be a long-term recovery, and quite difficult life circumstances. And I think having that sense of feeling looked after and kind of being aware of what's going on, I think is really important for people, even though it might seem quite small, when you're thinking about the grand scheme of things. So it was really nice to hear that there was this visibility of what was being done, and that people were feeling like people were actually trying to understand and genuinely trying to work together to help. So I think I've mentioned some of this already, but in terms of like the key learning is just getting in a room to talk is useful. So again, having those conversations, also having those disagreements, but being able to have them in real time, and talk through it to get quick decisions and agreeing those decisions. And as well, it helps. So some of the other feedback that we got from staff is it helps plan as well. So oftentimes, someone does need support from a range of services. However, maybe it needs to be staged support. It needs to be phased. There needs to be work in one area before work can start in another. But having that agreed beforehand, is really, I think, important and really useful, because again, a lot of the, you think about closing the gaps and then the exclusions, a lot of those gaps and exclusions come from those transitional points where someone says, you need to look at this and then we'll look at this. But actually that bit in the middle is often where people people fall down. And so having that people in a room to talk is really useful. And as well, it helps people understand, because part of it is, well, how do you actually support people with co-occurring and complex needs? One, everybody's different. Two, everybody's got different experiences. So having that is really useful. When talking to staff about why they've been referring people to MAC, actually one of the things that came up is that crisis situations are a key, or have been a key motivation for referrals into the consultation hub, which I thought was very interesting to see it almost as a bit of an escalation point in terms of things are maybe, or needs are escalating more than can be handled here, or need a bit of extra input, and that's a place to do it. Because often crisis services get a bit overwhelmed by people asking for help, and often it's driven by not really knowing where else to turn. So it's kind of given another route for that one, getting additional support, but also getting a bit of reassurance as a staff member that there's other people there who can help. But the informal is just as important as the formal. So again, a lot of this staff feedback that we've got, again, this hasn't been about just kind of passing cases over. It's been about having that discussion, and it's been about building relationships. So again, Benjamin talked about this idea that this is a really good starting point for a lot of things, and so that kind of moving into the informal space has been really useful, in terms of, because when we talk about in workshops leading up to this, when we've talked about describe a good relationship you've got across the services, the example people always give is, well, I can just pick up the phone to them, and then that's and that's what this is allowed. We've got that openness is empowering. So again, because there's that core membership, but there's also, it's a very open meeting where and that I think empowers people who are taking cases to bring other people in with them as well. So it isn't just, it's not a space that's being formally held by mental health and substance use services. So there's this kind of kind of closed atmosphere to it. People are very happy to bring in other agencies, and they're all very welcome there, and that's, feels like it's been really empowering in terms of the person who knows, or the staff member who knows the individual the most, is able to sort of almost bring in and pull on who they think they need to. I think that's been really empowering for people as well. And then again, continuous improvement is part of the interfaces too. So I mentioned the example of the GP referral, and so again, that's been, and then again, I put this in Jennifer's absence, but talking about clinically credible leaders driving the work. So Jennifer is a psychologist within the drug and alcohol recovery service. She's very, very credible locally. I think there's some people from Tayside on the call who will attest to that. And I think her being able to sort of push this from a bit of a project management as well as a clinical point of view, I think has been a really important in this as well, because she's been able to make the case for the change, but then also been able to actually drive it and sort of pull people into meetings and kind of follow up where things have maybe not gone so well, and I think that's been one of the key drivers of the work. So I think this has been my last slide, but in terms of that learning for improvement, so this is sort of some of the next steps based off the evaluation. So we're looking at basically developing a standard risk assessment and safety planning tool. So at the moment, it's we're meeting in this hub, but then everybody's got slightly different procedures once back out of it. Again, how to develop process to reduce crisis episodes. So is there an early intervention sort of approach that could be developed as that? Similar to John and Ian, how do we develop a training package for that? What should a joint training workshop and schedule look like, to understand kind of roles, what the boundaries between the services are as well, so again, so that maybe some of this can be replicated outside, so it doesn't have to always go to this discussion. Information sharing as well is part of the key one, is how can we improve some of that, and then some of that how do we develop a shared resource directory for quick references and signposting? And then one of the big ones is what's that feedback loop that enables services to receive timely feedback on referral outcomes. But then also, I think I'd add to that is one of the things looking at is how do we get the feedback loop from individuals themselves who've gone through the process. So again, that we can build that into the learning for improvement. So that's a whistle-stop tour of the multi-agency consultation hub. I hope that was all right. There's a Q&A, so I'm happy to answer any questions. But thank you very much.
Thanks a lot, Gregory. Thanks for doing that. And Dr. Jennifer Breen's place. I think there's a lot of learning there as well, and about a different approach to doing interface meetings that are, slightly more open or involve a broader range of services, but still kind of have that same benefits across the system in terms of identifying where continuous improvement can be made, identifying training needs for staff, and thinking about what next for services and what next for local systems.